we are going to get into some depth now on the federal response to sepsis, and we've got 4 speakers. I'll introduce each of them as they come up, but Dr. Owens, Dr. Guest, and Dr. Bell and Dr. Klein. Hear from each of them, and then we'll hear from them together, be able to talk amongst themselves and with us a bit here. So with that, Dr. Owens is here, and I'm going to introduce her as the Senior Research Scientist at the Center for Financing, Access, and Trends at AHRQ. And understand she's going to provide us with a fair amount of information of what they've been doing over the last year or so in detailing the problem of sepsis. So to Dr. Owens, thank you for being here.
Thank you very much. And thank you could you put the slides up, please? Thank you very much for inviting the Agency for Healthcare Research and Quality to be with you today and to speak with you about what we have done over the last year. I'm Pam Owens. I'm the Director of the Division for Healthcare Data and Analytics in the Center for Quality Improvement and Patient Safety. I'm a senior epidemiologist and a researcher at AHRQ. Very moved by the story that I just heard and that I've heard also from the Stauntons, as well as stories that I heard yesterday. So please keep those stories in mind as I talk about the statistics that we learned over the course of the year. Next slide, please. So first, I'd like to tell you a little bit about the Agency for Healthcare Research and Quality. We call it AHRQ. It is one of the operating divisions under the United States Department of Health and Human Services. It's a fairly small agency. Many of you may not have heard of it, so I thought I'd give you a little bit of background. AHRQ's mission is to produce evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable, and to work within the United States Department of Health and Human Services and with other partners to make sure that evidence is understood and used. We have a very unique focus within the department. Our focus is on healthcare quality and improvement. Our partners, like the National Institute of Health, help us understand the disease and develop cures, while CDC, the Centers for Disease Control and Prevention, focuses on research related to the public health system. And we focus on the healthcare services and systems. And in all of this, we work together across the department. AHRQ generates scientific evidence and actionable knowledge, funding health services research to understand how care is delivered and how it can be delivered better through quality, safety, equity, and value. We move that evidence into practice by developing tools, training, resources, and non-regulatory, non-punitive assistance. In addition, we monitor and provide feedback through measurement, data, analytics, and reporting for the state and federal policymaking. And that's what I'm going to focus on today. Next slide, please. We were very fortunate to receive dedicated fiscal year 2023 funding specifically for sepsis to address gaps in our understanding on the overall burden of sepsis to the nation. From the patient perspective, from the hospital perspective, from the state perspective, and nationally. This information will enable the successful allocation of resources and development of effective strategies to combat the sepsis crisis. And we are in a crisis. We initially focused on hospital care, but are exploring options to study sepsis in nursing homes and rehab facilities. Next slide, please. As I'm sure you are already aware, sepsis is the body's extreme reaction to an untreated infection. It causes the body to attack its own tissues and organs, leading to tissue damage, organ failure, and sometimes death. Anyone can develop sepsis at any age, though older adults and individuals with weakened immune systems are more susceptible. Sepsis can begin suddenly and requires healthcare personnel to be able to quickly diagnose and provide care to minimize the damage. Next slide, please. With the additional funding and the mandate from Congress, AHRQ did do a deep dive into the facts about hospital care and sepsis using the most robust all-payer data source in the country. The Healthcare Cost and Utilization Project is a voluntary partnership with 48 states and the District of Columbia. Through this partnership, we are able to collect the universe of hospital encounters, inpatient stays, and ED visits for all non-federal acute care hospitals in each state. That is information on all encounters, regardless of who pays for the care, including the uninsured, from 4,880 hospitals in the U.S. We use the HCUP data to examine volume, cost, and outcomes of care for sepsis from 2016 to 2021, with the hopes of continuing to look forward with data coming in now for 2022 through 2024. We released 3 statistical briefs earlier this summer, one providing an overview of the outcomes of sepsis for inpatient stays for 2016 to 2021. We looked at the rural and urban hospital differences in inpatient stays involving sepsis. We looked at racial and ethnic differences in inpatient stays involving sepsis. And this Friday, tomorrow, we'll be releasing a stat brief on the state variation on inpatient stays involving sepsis. Today, a little bit later, we will be releasing our comprehensive report to Congress on the burden of sepsis on hospital care in the U.S. I've provided the links to both the state variation stat brief that's coming out tomorrow, as well as the congressional report later today. We will also be releasing a blog on sepsis, and we'll have a data visualization on sepsis. This is all in an effort to make people aware of the extreme burden of sepsis on hospital care today. In addition, because ARC is focused on generating evidence and getting information out, we have 11 grantees currently focused on sepsis research. I'll talk about those at the end, as well as released a number of tools that can assist with sepsis diagnosis and treatment. So what did we learn? It's an understatement to say that sepsis requires additional attention. It is alarming in terms of what we found. Sepsis is the leading cause of hospitalizations following live births, with over 2.5 million hospital stays related to sepsis annually in 2021. That's a 40% increase since with the 1.8 million in 2016. It's on the rise. Sepsis is the leading cause of in-hospital deaths. In fact, 1 in 6 patients with sepsis die in the hospital. 1 in 3 patients with septic shock, the most extreme form of sepsis, die in the hospital. More than 2 million people were hospitalized with sepsis in 2021. The aggregate hospital costs associated with sepsis soared from $31.2 billion in 2016 to $52.1 billion in 2021. That's a 14% increase in the aggregate hospital costs annually. That doesn't count the costs of care provided by the physician. It doesn't count outpatient treatment, rehabilitation, long-term care, nursing homes, disabilities associated with post-sepsis, caregiver burden, or lost wages. That is just the hospital costs. And the majority of patients who survive sepsis in the hospital require extended care through home health, long-term care, or skilled nursing. Now, with that broad overview, I want to take a look at some of the details of what we found, noting that you can get a lot more information in those statistical briefs that I mentioned, as well as the congressional report. So what are the trends on inpatient stays involving sepsis? On the left-hand side, you can see that there was a 40% increase in the number of inpatient stays for sepsis, both as the reason for sepsis, which is the blue line, as well as complications for sepsis, inclusive of the reason for sepsis, which is the orange line. You can see that the percentage of hospital stays for sepsis and complicating stays, sepsis complicating stays, has increased from 5% of all stays in 2016 to now 7.5% of all hospital stays. It is the number one reason for hospitalizations in this country, excluding births. And yet, we know we are undercounting sepsis because it is not always identified. Next slide, please. Doing a bit deeper dive in terms of what do we know about specific populations. We know that the number of hospital stays for sepsis is on the rise for every population except for neonatal sepsis. Since 2016, among stays for non-maternal adults aged 65 years and older, we have seen an increase in the number of stays by 38%, so that in 2021, 1.4 million 65-plus-year-olds were hospitalized with sepsis. In 2021, nearly 1 in 5 65-plus-year-olds with sepsis died in the hospital. Among stays for non-maternal adults aged 18 to 64 years, we've seen an increase in the number of stays by 52%. In 2021, 1 million 18 to 64-year-olds were hospitalized with sepsis. In 2021, 1 in 7 18 to 64-year-old patients with sepsis died in the hospital. Among maternity stays, the number of women with sepsis increased 61%, such that in 2021, 8,000 maternal stays were related to sepsis. 4% of these stays resulted in death in the hospital. It's a statistic, but you heard the story. Sepsis is the number one reason for maternal mortality in the U.S. The number of stays related to sepsis also increased for children between 2016 and 2021, such that 33,400 children, 33,400 stays were related to sepsis in 2021 for children. 636 children died of sepsis in the hospital. Now, while I said that neonatal sepsis, that is sepsis among babies 0 to 27 days, has thankfully been on the decline, a 48% decline, so that there were 36,300 stays in 2021. In 2016, there were 69,000 stays. The in-hospital mortality rate has actually increased 45%. In 2021, 6.1% of neonates with sepsis died in the hospital. You can see from these graphs that with the dotted lines that COVID as an infection impacted the rates of sepsis stay, and COVID is here to stay. Next slide, please. Between 2016 and 2021, the aggregate hospital costs increased from $31.2 billion in 2016 to $52.1 billion in 2021. And as I noted in the very beginning, this is just hospital costs. It doesn't cover the costs related to physicians or outpatient treatment, rehabilitation, or long-term care. It doesn't relate to the cost of care related to post-sepsis. In addition, we know that of that $52.1 billion, $37.9 billion of it was billed to public payers, Medicare and Medicaid, for these sepsis stays. Next slide, please. In 2021, 1 in 6 patients with sepsis died in the hospital or in the emergency department. 302,300 patients with sepsis died in the hospital. 1 in 3 patients with septic shock, which is the most severe form of sepsis, died in the hospital or in the emergency department. Next slide, please. This slide shows that the majority of patients who survive sepsis in the hospital require extended care through home health, long-term care, or skilled nursing. Among those that survived, 60% needed extended care after hospitalization. Next slide, please. And we see disparities in the care. Black and white non-Hispanic individuals are more likely to be hospitalized with sepsis. Patients who are non-white and patients who are from vulnerable areas had longer hospital stays, higher average costs, higher mortality than their counterparts, suggesting that things can be done to address the crisis and need to be done. While the majority of cases are treated in urban hospitals, 15% of cases are treated in rural hospitals that also need the resources to treat patients with sepsis. Next slide, please. And we also saw that the population rates of sepsis do vary by state, suggesting again, there are things that we can do to mitigate the sepsis crisis. And we also know that there have been various responses at the state level to the treatment of sepsis. For example, in New York, Illinois, and Rhode Island, they all require the collection and reporting of sepsis-related data. New York, New Jersey, Illinois, Rhode Island, and Maryland mandate hospitals maintain and implement sepsis protocols. We've not, however, been able to address or assess the fidelity of the implementation of those protocols. In addition, we know places like Michigan has worked at a grassroots level to try to address sepsis across all hospitals, but you can also see more needs to be done. Next slide, please. I hope you take a moment to take a look at the statistical briefs and the congressional report that we have put out. That's a deep dive into what I provided at a pretty high level so that you can see what the real burden of sepsis is in the country. But I also want to highlight that ARC has funded a number of investigators to examine the evidence on the diagnosis and quality of care related to sepsis, as well as to consider the best ways to implement evidence. Here is just a list of some of those grantees. Next slide, please. And an additional list of additional grantees. I believe Dr. Prescott presented at this forum last year, and as an example of her research, there was an article in the American Journal of Respiratory and Critical Medicine that looked at the heterogeneity of the benefit from earlier time to antibiotics for sepsis. It was a highlighted article. Next slide, please. In addition, ARC tries to move the evidence into practice by developing tools, training, resources, and providing assistance. Here's an example of different things from the Effective Healthcare Program: making healthcare safer, sepsis prediction, recognition, and intervention. You can see the web link or the URL up there, as well as failure to rescue and rapid response systems and tools to help improve diagnostic safety. ARC is initiating a portfolio around diagnostic safety, and sepsis is a part of that. Next slide, please. In addition, ARC's 4 moments of antibiotic decision-making, including making the diagnosis, cultures and empiric therapy, stop, narrow, change to oral, and duration, have all become a part of our toolkits. It helps, simplify the complex process of antibiotic prescribing, including that for sepsis. In addition, we have a toolkit for using healthcare quality indicators to look specifically at postoperative sepsis. Next slide, please. And lastly, I just want to highlight the National Action Alliance, which is a departmental initiative that's looking at patient safety, making safer healthcare altogether across all operating divisions in the department, including making it safer as it relates to sepsis. Thank you very much.
Thank you, Dr. Owens. Wonderfully informative presentation. I've certainly got questions, which we're going to hold till we finish with the rest of the panel, but I want to take this moment to just let others know that if you have questions and you want to enter them, we will review them. We're not going to ask everybody every question, obviously, but to the extent that your questions fit into the dialogue, we'd happily have them in our list here. Next up is Dr. Foster Geston. Foster is the co-chair of the End Sepsis expert panel, which has been working with legislative teams and such on the sepsis bill we heard about earlier. Foster's got a remarkable history in this space. I'll let him tell you just a brief bit about himself starting off. But Dr. Gesson, look forward very much to hearing your thoughts on where we are with sepsis now.
Thank you so much, Dr. Dorfler. I'm still taking a breath from the stories, from the statistics. You know, the stories are overwhelming. The statistics are staggering, although not a surprise to many of us that have been doing this for a while. And I think that they certainly make the case for how and why we are so motivated to make changes and to act on these, whether it's the clinical community or the political leaders or policymakers. I think the combination of the two are just so convincing and provide the energy, I think, for all of us to continue this work. As Dr. Dorfler said, I'm Foster Guestin. I worked at the New York State Health Department during the time period in which we developed our sepsis quality improvement initiative, and I had been involved since my retirement from the health department with End Sepsis and others to try to bring some of what we learned and some of what we were able to accomplish and much of what other places around the country have been able to accomplish to a more national level. And Kieran spoke about some of our recent efforts with the legislation. I'll just touch on that briefly. I want to thank End Sepsis and Staunton's in particular, echo what the senator said about their history and their motivation and their accomplishment, as well as the patient and family advocates that have been working with End Sepsis and worked with us recently to tell their stories, which are not, as we all know, easy to tell. Our clinical advisors is certainly Senator Schumer. And then I also want to thank our federal partners. You just heard from one of them who have really taken up the issue anew and have worked with us collaboratively over these years to try to extend and expand the work that they do. So I want to talk a little bit about that progress to date. It's been mentioned. I'll touch upon it just at a very high level because I don't want to take away from our federal partners and what they're going to present. Not that I could, and have them tell their story, but give you a bigger picture. Also, because I think we're all who've been working in this impatient and thinking about what's around the bend. I want to just lay out a little bit of what we see as potential next steps beyond legislation and beyond the activity that we're doing now. Some of the things that either the data raises to us or things that we've been talking about or we think are our future needs. And then just briefly talk about a bigger picture, both nationally and globally, about why sepsis is so important. So I'm not going to be presenting a lot of numbers and statistics, but really talk about some of the broader issues. And as was mentioned, would welcome questions and discussion at the end of this. So let's go to the first slide. As we've been talking about, we have a number of, and we'll be talking about, we have a number of initiatives at the federal level that we're discussing today. I don't want to miss, however, or neglect to say that as much as we think the political and the federal agencies are important and state agencies, that what we're really directed at trying to do is to affect clinical care. And that can be facilitated and encouraged and can provide a regulatory framework and incentives from government. But ultimately, we're really talking about improving care for patients when they get into clinical settings, whether it's in the inpatient setting in any of the various ones or in the outpatient setting where they receive care. And the challenge, of course, is trying to create initiatives that not only look good on paper or feel good, but that actually translate into meaningful activity that saves lives and prevents the kinds of stories that we heard today and we've heard, many of you have heard over many years or experienced. So we do have, as we think about, as I think about the CDC and ARC and CMS initiatives, which have been both independent actions like the kind of work that Pam just described and also work in coordination, there are really three overriding themes of what we're trying to accomplish with this, I think. The first, as you heard from ARC, is the ability to have a comprehensive and updated set of data on the national impact, human and financial costs of sepsis in this country. We've had some in the past, but as we all just heard in those slides, putting it together and looking at across different populations and ultimately across different venues and states and types of care, looking across racial and ethnic differences and age groups, we come to a better understanding of just how large this impact is, not just during hospital stays or hospital costs, but as Dr. Owens hinted at, overall costs, which we have yet to calculate in terms of long-term care, rehabilitation, effect on jobs, family life, functional status, morbidity, and so on. We want to bring into the picture. But without that information, without that data, we lose the ability to be able to bring to policymakers, politicians, and the clinical community how important and relevant this is, as well as to be able to track over time whether our initiatives are actually having the intended impact or not. The second leg of this stool, if you will, is the development and promotion of health system standards related to sepsis care that are really get at the issue of structures and how to create systems of care that are ready to take care of and receive patients with sepsis who, as you've heard and as we know, their care is so time sensitive in terms of both recognition and treatment. And we have a model for this. We have a set of initial standards that had developed through the hospitals in Michigan and other places that we know will develop over time. We'll learn more about this, but articulating those standards and having them be taken up by the healthcare system is really the second leg of what we're trying to accomplish through our federal agencies. And then third and lastly, to create metrics that help guide our progress in improving outcomes for patients, meaningful outcomes for patients that include not just tracking hospitalizations, not just tracking whether the right care was delivered at the right time, which is critically important, but also how did patients themselves do? Were they able to walk out of did they survive? Were they able to walk out of the hospital? Were they able to return to their lives and to their function and to their jobs and to their families? And having those outcomes to help guide all the things that we're talking about, I think we feel are critical and a part of what we're trying to achieve in partnership with our federal partners. Kieran talked about and Senator Schumer talked about the legislative initiative, and just at a very high level, you'll have the opportunity. Some of you may have had the opportunity already to see the details of the bill, but in essence, we're trying to provide additional and continuing support to the federal agencies to do the work that I just described, to provide assistance to hospitals and health systems to implement these standards and metrics, to promote the standards, which I'm calling 1.0 for now, because we know that they will and they should change over time as we learn more about not only what's feasible, but more importantly, what's effective across hospital systems. That we have not just at one time, but that we have regular and updated and expanded reports on if you will, the state of sepsis in the United States, and that we develop and create and change over time and improve over time meaningful outcome measures that are meaningful both to clinicians, to policymakers, and most importantly to patients as well. And in our current iteration, we have noted since the beginning the fact that metrics and the discussion about pediatric care and maternal sepsis, for that matter, have been sorely lacking. We think that there's a tremendous opportunity to start that work on looking at pediatric sepsis, looking at pediatric development of pediatric quality of care metrics as well, because you saw what the numbers are that Pam described, and you heard the story about maternal sepsis as well. Next slide. So what's next? Well, we absolutely next and right in front of us is making sure that the current legislative agenda becomes a reality, and that's going to be work over the next months, year, however long it takes to make that happen. But we're also, looking around the corner to think about the importance of trying to find and develop and create financial and logistic support, particularly for resource-constrained hospitals, to incorporate the protocols and elements and staffing and leadership to provide excellent sepsis care. And if you look at some of the data on this, which from the CDC report, it's not hard to see that smaller, more resource-constrained hospitals may have more challenges and may particularly benefit from having more resources and support. And we think we need to think about how to make that happen, how to help them. We have focused much of our effort on the hospital and inpatient setting, but as has been alluded to, there are important issues related to prevention that reach into much of the work on vaccinations, on early identification, on testing, on pre-hospital recognition, both in ambulatory settings and home care, in primary care and so forth, as well as the other end of the spectrum, which is how we care for people that survive sepsis in the post-hospital and rehabilitation phase. And how can we do that better? And how can we understand what high-quality care for sepsis post-hospitalization looks like? We also, as we go down the road, I think must use the data and the information on how well patients are doing and how well hospitals are doing to make changes to both the core elements and the process metrics, so that we're sure that we're staying true to the purpose. And the purpose, again, is not nice words on paper, but actually to make a difference in people's lives and to prevent sepsis and prevent deaths and disability from this terrible and common disease. And then investment in both primary research, bench research, as well as clinical quality research funding, whether through NIH or ARC or other agencies or CDC and private agencies and so on. We think that this is very important. So sepsis is complicated, and there are a number of issues that really in the science and in treatment that are as yet unclear or undecided. And so we need more research on all levels, both in terms of basic science research and applied science, if you will, to how systems and how clinical care can improve and reach the kind of level of care that we're trying to achieve. Last slide. I'm not sure that this audience needs this reminder, but it occurred to me as I was putting the slides together and thinking about this, that there's so many ways and so many reasons why focusing on sepsis is compelling. I mentioned the stories, we had the statistics, but right in front of us has the recent experience of the COVID pandemic, which as you look at the data and the deaths from COVID, which were largely sepsis deaths, the need to improve sepsis care is both global and urgent. It's not going away. And if the stories and the statistics that are presented are not compelling enough, we have only to look to our recent history. We may feel as if we are done with COVID and COVID-19. Certainly we're out of the pandemic range, but COVID clearly is not done with us. We have influenza, which remains an issue for us, and deaths from influenza, which many of which are preventable. We have most recently Mpox in parts of the globe around which there have been concerns about and alarms about treatment and possibilities of spread. We have antibiotic-resistant, quote-unquote, superbugs, which are not going away and present a real challenge. And then we have whatever mutation happens next to perhaps common viruses and bacteria or new novel entities, which present challenges both in terms of infection and ultimately in terms of sepsis. So this slide is really just meant to remind us and to think broadly and globally about how important and the many reasons why it's important for us to try to get this right. It's about what's in front of us, but it's also about what's potentially around the corner as well. So with that, I'll just remind folks to, they have questions to submit them, and look forward to the discussion and the other presentations. Thank you.
Part of today is hearing how much work's been done. Part of today is recognizing how much work really needs to be done. And I think that's a big piece of the purpose of all of this, and a big piece of the work with the federal government. And I'll use that as a segue to our next speaker, which is Dr. Michael Bell. Dr. Bell is the acting director of the Division of Healthcare Quality and Promotion at CDC. CDC has been partnered with the End Sepsis organization for a while now. Several CDC directors ago that I remember visiting the headquarters in Atlanta with Kieran and Orla, and meeting many of the wonderful folks who work there. And Dr. Bell, I look forward to your presentation and update on the work of your group. Dr. Bell, thank you.
Thanks for the introduction. Everyone, Mike Bell, CDC, the Division of Healthcare Quality Promotion. First and foremost, thanks for letting me join you today. This is always an important event. I have to say that it is extremely energizing, even though it's challenging and hard. The energy and determination that I hear, that I see demonstrated by the previous speakers, by the field at large, is extremely encouraging. That doesn't mean there's not more to be done, but it is such a sea change in terms of where we are now versus where we were a decade ago. Speaking with staffers and members of Congress yesterday, I can only congratulate this group of partners for the work that's been done to change perceptions about sepsis. The fact that essentially everyone we spoke to were ready to get on board, were ready to acknowledge there was no convincing that needed to be done, very different from the past. Frankly, a lot of that is directly attributable to what the Staunton family has done for the past decade. But also End Sepsis as a group has been extremely effective in doing that, and I'm very grateful for that work. On the note of gratitude, I will also say that it's been amazing to see what can be done with the resources that Senator Schumer's office has made available to us. Those resources are frankly game-changing. If I'm to share some inside baseball, we work on a wide array of topics to protect patients across the spectrum of healthcare. Most of those, if not all of them, if they're neglected, if they don't get prevented up front, could lead to sepsis. And so rather than having to remove resources from there to focus specifically on sepsis as the outcome, being able to dedicate resources to the topic of sepsis is something that is so much more effective and very, very exciting to be able to do. I'd like to share a little bit with you about what some of those early resources have achieved. The first one is significant progress in terms of metrics. Those of you in the health systems world, I think, will recognize that the things that we measure are the things that we're able to get better on. In fact, if you flip it around, everything that we've measured through the National Healthcare Safety Network, that's our tracking system nationally for healthcare-associated infection outcomes, we have managed to drive down those rates time and again. The combination of tracking progress and having a concrete package of interventions that should be implemented is extremely powerful, and it's something that we are very excited about doing with sepsis. To that end, there are outcome measures looking at who got sepsis and what happened to them within their hospital stay that are being finalized right now. There's an adult measure, and that'll be shortly followed by a pediatrics measure. And in addition to that, there are structural measures, which I'll say a little more about in a moment. But both of these things are worked on in close collaboration with the Centers for Medicare and Medicaid Services. That's CMS. CMS partnership for us has been incredibly valuable in terms of promoting the uptake and adherence to things that we recommend. So we're able to recommend things. CMS ties adherence to those recommendations to payment and reimbursement. And that, of course, is a very powerful stick-shaped carrot, if you will. It is the most efficient way that we've found to drive change across the health system. That is something that we're looking forward to leveraging this coming spring. As some of you may know, CMS incorporates new measures for consideration on a cyclic basis. And so this coming May, we'll be proposing that they consider these measures. I mentioned a structural measure. So as opposed to outcomes, structural measures are things that are defining what ought to be in place. For sepsis, that ties directly to our recently released core sepsis measures, or core practices rather. Those include an array of things, but if you generalize and capture them from the top, it starts with leadership commitment, having the people who make decisions at the health system decide that they're going to tackle sepsis in a serious way. Second of that framework is identifying somebody who is responsible for tracking, reducing, preventing sepsis across that health system. And then the third is accountability, that they are held accountable for doing that. Thereafter, there are resources, making sure that there are appropriate pharmacy and other capacities available, the measurement and tracking of progress, and then the feedback of those results. That cycle of effort is what we've seen be successful in improving antibiotic use, in maintaining appropriate infection control. All of these are sort of built on that same pattern based on an understanding of what actually has traction and can be implemented successfully in healthcare settings. The accountability piece is really hard to overstate. The combination of being responsible, but also being at the right part of the agency in terms of structure and authority is something that we've seen be an incredibly important part of successful implementation. To that end, we are very much looking at how senior leaders in health systems can take on the mantle of sepsis prevention and address this with us. I'll say that a lot of the progress that's been made is focused on hospital care. That's where we have the greatest access to personnel capacity. We have data systems. There's the ability to move forward fairly rapidly there. And that is all good. I will flag that, as Dr. Geston mentioned, it's not an even playing field across all healthcare systems. I'm very concerned about small and rural facilities. I'm concerned that we may not be successfully measuring as well there, not to mention preventing. The resource needs are variable depending on where you go, and learning from those parts of the health system how we can help the most, how we can help them make progress is part of what we're investing heavily in right now. The other aspects of healthcare that I think are still very challenging and not well addressed include pre-hospital care. The messaging that I'll talk about in a moment is working to make pre-hospital recognition better, but the care delivery before arrival at hospital is something that I think needs to recruit more active engagement from our emergency services colleagues, ensuring that EMS staff are tuned into the issue of sepsis, know when to push hard for those individuals that need urgent care. They do an amazing job day in and day out, and recognizing those skills and promoting them as a strong partner in this field, I think is crucial. The post-discharge component of care is another area where I see current limitations and some need for evolution and greater capability. Long-term care is obviously central to that. Our nursing homes, our rehab facilities, skilled nursing facilities are places where people with tremendous risk for sepsis outcomes are sent after hospitalization. Understanding how we can do a meaningful job in a setting where medical care providers are not always well supplied, shall we say, where individuals with different types of training are actually providing care, doing dressing changes, administering IV fluids, and so on. Those staff probably need a very different type of training and information source to do the right thing when it comes to sepsis. And so tailoring our capacities to that is another component that I think we need to pay attention to. Maternal sepsis postpartum is a parallel to this, and there you're dealing with people who are at home, as with other post-op individuals. So I see there being needs there, and I'll speak a little bit about innovations that I think are necessary. But before I do that, I want to share a little bit about information push that has been possible thanks to those resources that were made available this year. We heard loud and clear that there needs to be more understanding of the risk of sepsis and what to do about it across the spectrum of not only healthcare, but the general public. And so we made a tremendous push to incorporate more messaging to places where, for example, children might be receiving care for a wound or a scratch, places like summer camps, schools, and the like. I'm very happy to say that the scale of information we've been able to push out is extraordinary compared to anything else we've seen. We had over 500 million media points registered on the sepsis topics thanks to these pushes. Another 12 million of paid media that we arranged specifically, which is a new activity. The extremely high-profile publications in journals like the Journal of the American Medical Association, framing the importance of the topic and the systematic implementation of improved care. And then over 6,000 trainings for medical staff across the spectrum through Project First Line and through programs that actually deliver continuing education credits that can be rolled into professional licensure and other systemic training requirements. Those are all extremely exciting. There's more to be done. We are excited about the upcoming waves of communications that are already in planning and in progress, and those will get continued to be pushed out all through the year. I mentioned innovation, a little bit of aspirational thinking to share while I have you. One is technological. I think that many of us are wearing smart devices right now, and that is, I think, a tool that can be leveraged to do a much better job of helping clinicians who may have to send somebody home because they don't specifically require hospitalization at the moment, but recognize that they could actually not go in the right direction and need to be hospitalized. Being able to send somebody home with a real-time monitor that sends appropriate alarms to the right people could be extremely helpful in reducing the time to recognition and appropriate hospitalization. I think that the opportunities for improving diagnostics and treatment possibilities are huge. Those aren't things that CDC does. That's certainly more in the NIH world, but I do think that there is incredible need for innovation in those areas. If there is a rapid marker and diagnostic ability to identify people who could be at risk for sepsis in the coming 24 hours, that would be a game changer in terms of how we manage patients and care for them. If you combine that with what I said about emergency medical services, if that was deployable in the EMS field, you can imagine really changing how we address individuals at risk. In terms of therapeutics, obviously, there's a wide array of needs there, and I won't go into them, but it's something that I hope will be invested in further. The last thing is scale. And one more quick thank you to the efforts of Senator Schumer and Sepsis in terms of trying to help us scale up this activity. Every individual in the healthcare setting is at risk in some way of descending into sepsis. Being able to cover that huge waterfront in a way that is effective and beyond effective, sustainable. I think that is something that we are very much invested in doing. Sustainability is the note that I will leave us on. The issue of sepsis is something that we can tackle and we will tackle. But the minute we step away or shift our attention, it will be back. It is one of those perennial issues that needs constant and ongoing efforts. And so that sustainability piece is something that I certainly applaud our colleagues for investing in upfront. That is a crucial component of success. So with that, one last thank you for the partnership, for the efforts, the progress, and a commitment to continue to work with you moving forward. Thanks.
Thank you, Dr. Bell. You have to make one quick comment here before we go on to Dr. Klein. I was listening as you were talking about the communication piece, and one of my anecdotes that I'm quite happy to be seeing is that the lay press is using the word sepsis. I'm not seeing blood poisoning anymore, which used to frustrate me to no end, and I'm not seeing so-and-so died of a serious infection without mention of sepsis, except for rarely. It's not completely there yet, but seeing the word sepsis actually called out in the lay press, I think, is an enormous piece. And they're usually referring to the CDC definition. They've connected to the website and pulled some information off in doing that. So I just want to throw that in as we continue forward, and then go to Dr. Klein and come back and get questions for the panel here.
Thanks.
So to our next speaker, I would like to introduce Dr. Ron Klein. I had the pleasure of meeting Dr. Klein in person last year in Washington. Dr. Klein is the Chief Medical Officer for the Quality Measurement and Value-Based Incentives Group at the Center for Medicaid and Medicare Services. I probably got the Medicaid, Medicare in the wrong order there, but to you, Dr. Klein, thank you so much for being with us.
Thank you so much. Good afternoon to those of you on the East Coast. Good morning to you, for those of you on the West Coast. I had the pleasure of speaking for the first time on sepsis at your group about a year ago. And at that point, the sepsis portfolio, if you will, had been given to me about 2 weeks prior. And I was a little bit unsteady on my feet. And now a year later, I feel like a grizzled sepsis veteran, deep into the fight and happy to, a happy warrior, I guess is the term. Have met with many, many folks on the issue. My background prior to coming to government 10 years ago was as a pediatric hematologist oncologist. I was 20 years in practice before I came to government. I continue to volunteer at Johns Hopkins in pediatric oncology and continue to work in a pediatric ER on weekends just for fun. This is I'm going to challenge all the other physicians in the audience. This is one of my patients. This picture, who was 15 years old when she had leukemia. She's now a 35-year-old woman with 3 kids, and she put the little leukemia ribbon on her arm. Wonderful quote: "You never know how strong you have to be, and how strong you are until being strong is your only option." And my favorite thing is I have my initials tattooed on her arm in between the leukemia ribbons. So that's I view that as the highest possible honor. And the fact that she's grown up and got married and become a mother is a wonderful, I think, thing for what our field does. So I have met lots of personal experience with sepsis as a pediatric oncologist. One patient in particular who came in with fever and neutropenia, which in my world is an emergency, and immediately wrote the order for antibiotics. By the time it got sent down to the pharmacy, by the time the pharmacy made up the antibiotic, and by the time the pharmacy tech brought it up from the floor to the floor, by the time the antibiotic got hung was a couple hours, and the kid became septic and spent the next six months in the ICU. Now, it has a happy story because he did well after 6 months in the ICU, but it's really something that shouldn't have occurred. And so I feel passionately about this topic as a physician, and I'm happy to be here speaking with you. The world is a small place, and I was in a family event the other day, a couple of weeks ago, and one of the people, distant relatives, was talking to my wife and saying how she had been septic. And she was fine now. And my wife said, "Oh, my husband is very interested in sepsis." And it turns out that she was in New York State, and she got wonderful care because she was in New York State. Perhaps would have gotten wonderful care elsewhere, but she got wonderful care in New York State, perhaps because of the guidelines that have been promulgated. And just a single thank you to the Staunton family, from that person who got wonderful care. And on to the next slide. So I have no financial interests. Next slide. Next slide. So why does CMS measure quality? And so that's sort of, the question. CMS in 1965, when it was HCFA, Healthcare Financing Administration, basically was the payer of claims. And now we've become much more than that, and we measure quality. And so why do we do that? And sometimes, cranky physicians say, well, why does CMS even measure quality? And I think it's important to look at things more broadly and say that every successful organization measures the quality and the safety of its products or services to remain successful. If you walk into a retail enterprise, they're going to measure the quality of the products they purchase from the manufacturers to ensure customer satisfaction. If they're getting a lot of returns, they will probably find a different manufacturer to purchase from. Customers comment on the quality of the products and services they purchase. Before I buy something on Amazon, I usually look at the comments to see what's going on. And healthcare is no different. It is about 18%, 17.8% of the U.S. GDP. I always tell people, to put that in perspective, healthcare would be the fourth largest economy in the world. The U.S. healthcare spending would be the fourth largest economy in the world if you measured it by GDP after the United States, China, and Japan. It's greater than the GDP of Germany, greater than the GDP of the UK or India. And CMS is a payer of healthcare services, about $1.5 trillion a year. And Americans are a consumer of healthcare services. So it is right and proper that we are involved in quality measurement. Next slide, please. So this is a little bit of a review from last year, and what we're doing now, I believe most of you are familiar with, is what we call the Severe Sepsis and Septic Shock Management Bundle, or we call SEP1. And this is a process measure. And for those of you who are not steeped in quality measurement, this basically says, are you doing all of these things that we think are the right things to be doing to assure the best possible outcome? The gold standard, if you will, in quality measurement quite often are outcome measures, and I'll speak to that a little bit differently a little bit later. But this measure looks at various different lab tests if they're obtained. It looks at fluid resuscitation. It looks at getting antibiotics in within 3 hours. It looks at repeat assessment of the patient. And it aligns with Surviving Sepsis campaign. It started in 2015, October 1st. It was in the inpatient quality reporting program from 2015 to 2024, which meant that it was a reporting program, but did not have money tied to it. And I mentioned this last year, is that in fiscal year 24, so October 1st of 2023, it came into the hospital value-based purchasing program. So it now has money tied to it. And as Mike Bell was saying, there's nothing like changing people's payment to get their attention. Government being government, it started in fiscal year 24. It will affect payments in fiscal year 26. And this measure is in both the IQR program, so it remains both a reporting program and a payment program. So it's there in terms, from both standpoints, even though the hospitals have to submit data just one time. Next slide, please. And so this is just what I said before: is that it's a reporting and a payment program. And the fun fact here, maybe my third bullet, I worked on the oncology care model for 5 years at the Innovation Center before I came to my present job. And one of the interesting things when you spoke to the oncologists at various practices, that there were payment incentives in that model as well. And we didn't publish how physicians did, nationally, but within a practice, those metrics were available to physicians. And what you heard from the practice leaders is that physicians, and we're a competitive lot, were more interested in how they were doing relative to their peers than the dollars that were necessarily attached to that. So I always say that money is important. Money drives change for better or for worse, but also your own sense of self and your own personal pride, whether it's a hospital's pride or a physician's pride, can affect change as well. Next slide, please. So as I was saying, I work in the pediatric ER at a hospital in the outskirts of Baltimore, and I had an ER tech who was wearing, your ID badge and all the different various things that the hospitals give you to put on your ID badge so that you always have it handy. And I noticed this sepsis bundle of care that was there. So that to me, when a hospital administration goes to the trouble of laminating a card and giving it to all of their ED folks, that tells me that we're affecting change. It tells me that we've gotten their attention. So it's a small thing, but I viewed that as a positive change. Next slide, please.
You get torches?
Yeah.
These torches? Okay.
Sorry?
So
I'm sorry. All right, so I'll keep going. So is sepsis one changing hospital processes? So if you go back to 2015, Q4, when the SEP1 measure started, about 30 some odd percent of hospitals were complying with the SEP1 composite measure. And if you look up at 2022, and it's still about the same in 2023, 2024, fortunately we haven't gotten past that 60% threshold, but it's gone from basically 30% to 60%. So in I guess 7-8 years, we pretty much doubled the compliance with the sepsis SEP1 measure. I'll take a step back and say this is not sort of a theoretical compliance with a sepsis management bundle. These are the things that the best people in the field have said are important to do to improve survival. And so we've doubled that with this process measure. Next slide. And these are articles that you're probably familiar with that have been written about the SEP1 measure. And this is one that showed, I believe this was about an absolute, I think a 5% decrease in sepsis mortality in hospitals that were compliant with the SEP1 measure. I'm sorry, in terms of patients that were compliant with SEP1 care versus those that were not. Next slide. And this is one looking for at New York State sepsis mortality, and after the guidelines were promulgated. And this also showed, I believe, about a 4% absolute decrease in sepsis mortality with following guidelines. Next slide. And then this is basically from New York State Public Health Department. It ends in 2019. I have not been able to update it. That darn COVID seems to have affected everybody's data, but you see an 18% relative decrease in mortality over 4 years, from 28% down to 23% over 4 years. So again, the regulations have gotten people's attention. The SEP1 measure has gotten people's attention, and so changes are occurring. Next slide. So I think I mentioned I'm a pediatric hematologist oncologist. So this was actually a presentation at last year's conference, and I was struck by it. And I am proud of my pediatric colleagues because there's been a lot of contentiousness around the SEP1 measure, and the pediatric colleagues in the Children's Hospital Association adopted this voluntarily to see what effect this would have on their outcomes. Next slide. Next slide. And what you see here are, in the left column, the 3-day sepsis attributed mortality, and the right column, the 30-day attributed mortality. And you see that with critical sepsis, being compliant with the measure showed a 48% decrease over 3 days, 48% over 30 days. Similar with suspected sepsis, being compliant, you had an 83% decrease in mortality, 80%, 30-day mortality. So in the pediatric world, complying with the SEP1 process measures has shown an effect, just as complying with it at the adult level has shown a success. And I will touch on this a bit later, but we are working with CDC now to have a pediatric sepsis measure, working on a pediatric sepsis measure. I'll touch on that a bit later. Next slide. So as Dr. Bell said, this is joint work with CDC to develop a sepsis outcome measure. And we're hoping to have it submitted to what we call our merit/muck process in 2025. That'll be May of 2025. That is, hopefully everything goes well. And for those of you who are physicians and those of you who have contact with physicians or other clinicians, one of the ongoing arguments in quality measurement is, don't measure my processes. Don't tell me how to take care of my patient. Just look at how they do. So we are sensitive to that. And so there has been ongoing work to generate a sepsis outcome measure. Again, that is work underway now CMS in collaboration with CDC. And we hope to start that down the quality process in May of 2025, which would mean it would be discussed in our rulemaking process in January 26, hopefully make it into a fiscal year 27 rule. That's if everything goes according to plan. So things have to sometimes blow up, and hopefully that won't occur, but that is our goal as we speak. Next slide. So I think part of as we talk about the sepsis measure, we have, how do we define sepsis, and how do we risk adjust? So those of us who work in government will tell you that whenever we do anything that measures patient quality, we usually have a line out the door of hospital systems and clinicians telling us that their patients are sicker than everyone else's, and therefore it's not fair to them. So we have to do what we call risk adjustment. And then in sepsis, everything, those of you who live in this world are familiar with the SIRS versus SOFA criteria, and it's sensitivity versus specificity. How we make sure we capture everyone, even if a few are what we would call false positives, and that's an ongoing debate in the sepsis world, and I'll touch on that in a minute. How do we define sepsis? We use ICD-10 codes. We look for evidence of organ dysfunction. We use of antibiotics, procurement of blood cultures. And then one thing that's coming up now that CMS has talked to several entities on, we have new biomarkers coming out to diagnose sepsis, and they are imperfect. And so the question is, but they continue to be approved and hit the market. So the question is, how do we incorporate those results, if we do, into any type of sepsis measure? And there are obviously other potential clinical parameters. Next slide. And so just quickly, how these are our decision points. Is it Medicare patients only? Is it all payers? And an electronic clinical quality measure we call an ECQM. That's able to capture all hospital data from all payers. Right now we have excluded populations, pediatrics and postpartum. We're working on a pediatric sepsis measure with CDC. There's a little bit of complexity there because children have different parameters for vital signs, especially young babies, and postpartum measures. There is a CMS severe obstetric complications measure, but it only looks at complications within the hospital admission, within the delivery admission. So if you go home and come back a day later, that's not captured. We're working to change that. And how do we look, what time period do we look at? It seems to be a 30-day in hospital mortality rate. And I would just underscore for everybody, we are wise in the ways of folks trying to improve their scores on systems. And so wouldn't it be nice if you just had to discharge somebody to hospice and they didn't die in your hospital, and then you didn't, and that didn't count against you? And so we are wise to that. And so the outcome measure that we're working on would also include discharge to hospice. Non-bacterial infections, COVID, influenza, RSV. And again, for better or for worse, because of the different levels of vaccine acceptance across the United States, there may be some risk adjustment that has to occur there. And then obviously conditions present under administration. If you're a tertiary care center and you get a very sick patient, that shouldn't count against you as though you had a healthy patient come in through your ER, or a not so sick patient, I should say. Next slide. I will go past this. This is sensitivity and specificity, which I think everybody understands. Next slide. And then, basically, this is what I wanted to touch on, because we have these knock-down, drag-out fights about SIRS versus SOFA in terms of which is the way to measure sepsis. And there are varying definitions, and they have different sensitivities and specificities. And the definitions of sepsis should align with the research and/or policy goals of the program. So what I mean to say here is the goals of academic research and health policy may be different. So in academic research, you may want to have a very, very specific measure because you're looking at sepsis. And in health policy, you may want to make sure that everybody gets that care. You don't leave everybody out. And so we may have different definitions with different sensitivities and specificities. And I would like to point this out. The criteria are too sensitive in terms of diagnosing sepsis, then some patients who are not septic will receive unnecessary doses of antibiotics, hopefully not more than 1 or 2 days worth, because we remember to stop them. If the criteria are too specific, then some patients who are truly septic will not receive necessary antibiotics, and they may die of untreated or delayed treatment of infection. So we in health policy, when we talk about specificity and sensitivity, we look at what are the risks on either side. Next slide. And I recently read the SEP3, the paper on SEP3 published in 2016 in JAMA. And this quote just jumped out at me. Again, perhaps just scarred too much, I should say, by the ongoing definitions of what sepsis is. And the authors of this paper, this is a quote from that paper, said, neither QSOFA nor SOFA is intended to be a standalone definition of sepsis. It is crucial that failure to meet 2 or more QSOFA or SOFA criteria should not lead to a deferral of investigation or treatment of infection or to delay any other aspect of care deemed necessary by the practitioners. So we have the SEP3 criteria that are out there. They're valuable. They're perhaps more specific than the SEP1 criteria. But the authors of this paper are telling us, don't just look at our criteria. Look at the patient in front of you. I think one more slide. And I thank you for listening. I look forward to the discussion. This is a slide from Montana, Great Falls, where I did a locums a few years ago in pediatric oncology, the beautiful state. And on to the next speaker.
Thank you, Dr. Klein. Our next speaker actually is all of us together here for a little bit. So if we can bring the rest of my panel here, Dr. Owens, Dr. Bell, Dr. Geston, split this screen up a little bit, to some manner or another. Take me out if you don't fit us all in there. There you go. As the moderator, I get to start, and then hopefully I'll get some support from the rest of the panel here, and I'm sure you have questions for each other. My first question I'm actually going to address to Dr. Owens, because the data came from you, though you may not be the best person to answer this and such, but I was struck by the direct cost to hospitals, 31 billion to 52 billion within that time frame. And you've had a very clear disclaimer of all of the healthcare costs that are not included in that number. And both Dr. Bell and Dr. Klein, I think Foster as well may have touched on it, the impact of these costs on rural and hospitals serving underserved communities and such. Is there anywhere in this process with your data or with the bill now introduced in the Senate with CBO or the like, where we're actually going to have a number showing how big the actual cost of this problem is in dollars? I mean, we don't get into quality adjusted life years and things like that and really blow the numbers up. But I'm just struck by the massive amount of money that we are almost certainly spending in the care of this community and the increased attention that even the current level should be taken to.
So from all that we were able to provide for the congressional report from ARC was based on the Healthcare Costs and Utilization Project, and it was based on charges that were converted to costs based on CMS's cost reports. That said, I think this is actually just a small portion of what we really need to do and think about all of the other databases that need to come to play, both from the outpatient side, the rehab side, et cetera. And so ARC would like to undertake that analysis to be able to really look at what are the economic costs. We were not able to do that in the year timeframe, but I agree with you. This is just a very small portion of it.
Is the data necessary to do that available to you with appropriate funding, or are there data sources that are just not there? What's the practicality of doing it if the money's provided?
If the money is provided, there are ways to use data that we would have access to. And there is a part of which we would need to come up with some sort of weighting algorithm. HCUP is the only database that includes uninsured patients. So to be able to capture that the cost to people where there is actually no claim, there's nothing to say what the dollar amount is, will have to be extrapolated. But we certainly have information from a variety of sources, from private payers, from Medicare, from Medicaid, et cetera, to try to get at those costs. And there are ways to do it.
Thank you. I look forward to that very much. I think it can be very impactful. Not and the data you're providing right now, as is really digested, particularly by legislative leaders, I think has opportunity to be quite impactful in the current discussions. My second question is to combinations of Dr. Bell, Dr. Klein. Foster, not leaving you out, but I know you've got your own comments here. Dr. Bell, you actually were the first because you spoke first to mention the partnership around outcome measures and the expectation in May that you are going to be sharing these with CMS for them to begin processing through the various steps that they can turn into things that are monitored in the healthcare environment. Any hints as to what's in there and any information you can provide on how you've gone about determining your outcome measures?
Short answer is no, no spoilers. The process here really is a combination of technical and sort of pragmatic socialization, right? We don't want to release something that is going to be either unacceptable or somehow meet resistance within the field. You have, I'm sure, plenty of colleagues in academia who would be glad to talk about gray zones and split hairs for days on end. And we want to make sure that we are transparent and able to produce something that is understandable and rational to at least the vast majority of parties. To do that, we're looking at the measurement and making sure that it doesn't misrepresent, doesn't misidentify in ways that are problematic. It's a work in progress, but as soon as we're able to share that publicly, we certainly will.
And Dr. Klein, to you, if I could, I mean, you look like you're going to comment, but I'm going to just add one piece of that question, which is when these proposed measures come to you, and that might be where you were going to go, what's the process and how quickly can these be turned into measures that then begin to impact care?
Yeah, I'll also thank you. So I just wanted to correct Dr. Bell just slightly. So I am actually a part of the CDC work group on developing the outcome measures. So CMS is co-developing this with CDC, although it's under CDC's guidance. So that we're actively part of the process. We're not just waiting for it. The process, and again, intended to bring everybody's input in place, is that if we can get this measured by what we call the merit process, which is an acronym that I've forgotten, by May of 2025, which is our goal, then we can get it into so the May of 2025. Then it goes into what we call our primer, PRMR, pre-rulemaking measure review discussion, January of 26, which gets into the fiscal year 27 rules. So basically, October 1st, 2026 would be when we would hope to have this measure, in our IQR program, as long as we can have the work completed and get it to our merit process by May of 2025.
And Foster, to you, you've been co-leading the process of working with the various government entities and representing Sepsis. So my question to you is, what questions do you have for the group, just to throw it to you as the next opportunity?
Well, thanks. First of all, the presentations were terrific and the work is even better. So, again, thank you all. I guess one of the things that pops into my head as I listen and think about all three agencies is the connect. We didn't talk as much about the connectedness of this work and the process and the nuts and bolts of how we can help, how we can help you or maybe others connect the work in a more, in a more vigorous way. For example, and we've talked about this in other forums, as we get hopefully an outcome measure from CMS that is acceptable and useful, pair that with what's going on in process, and look at the adoption of or non-adoption of CDC standards, and we look at what's going on with sepsis nationally. What's the process, as you think about it, that would help to bring the folks who have responsibility for those different pieces together to basically, I'll use a tired term, to do mid-course corrections, to do continuous quality improvement, to to really take a hard look about whether the things that we intend are actually having the effect that we want. Is there a need to make those connections in some way that they're not now? Is there some role that, either End Sepsis or others can play to help to facilitate that? Hopefully that's a clear question, but.
I'm happy to start. So I think not just in sepsis, but in quality measurement broadly, there's a lot of work between CDC, ARC, and CMS to make sure that we align. I think that's been one of the goals of our group director, Michelle Schreiber, who was the quality measurement director at Henry Ford Health System before she came to CMS. And she said that she had an Excel spreadsheet with 660 different quality measures, and most of them were variations of the same thing, because this insurance company said it this way, CMS said it this way, ARC said it that way, CDC said it that way, and basically, I think a lot of the impetus to decrease the measurement burden is for us to align on measures. So that's the reason that CDC and CMS are working as closely on this, so that it does align. The process is an open one that values participation. So assuming it gets submitted in May of 2025, there are public meetings in January of 2026 on that basically review this measure, and public comment is welcomed and accepted. And so having all the folks who are interested and passionate about sepsis line up in January of 2026 to say what a great measure this is, and hopefully it will be probably be the best help that you can give the cause.
Dr. Klein, if you get to the point you have this approved measure, what happens to SEP1? Would there be an expectation it would be sunset, or would there be an expectation that it's going to run in parallel?
Yeah, to be determined. So the process, a quality measure has to be in the inpatient quality reporting program, which is a non-payment program. It's a reporting program only for 2 years before we can move it into a payment process. So right now, SEP1 is in a payment world. So the question is, would we remove SEP1 from payment once an outcome measure is available, basically then taking away payment from the process? Do we run them both in parallel, and how do we do that? So like I said, TBD, but again, the important point for people to know, and again, government is very transparent, and we have to give people proper warning and all of those things. So before we can move the hopefully soon to be proposed sepsis outcome measure into a payment program, it has to be in patient quality reporting for at least 2 years.
Thank you. Any questions from any of the rest of you for each other?
Well, just responding to Dr. Gaston's question, I do wonder about, oh, hang on.
You just went to the dark.
No, I was holding too still. That's what happens when I concentrate. The automatic lights go off. The question I have is not so much can you facilitate more interaction amongst this core group that we have today. I'm wondering about the people who aren't engaged with us today across government. And some of those groups, I already mentioned NIH, not to lean too heavily on them, but I do think that your input could help focus research agendas in a way that would be very exciting. I wonder about groups like BARDA and ARPA-H, who are interested in putting money into moonshot type things. And lastly, I wonder about the Department of Defense. Our soldiers die septic deaths constantly when they're in trauma situations in the field of war. And there must be attention to that in the Defense Department that I'm not aware of. But I can imagine that from your perspective, you have an opportunity to pull those things together in a way that could actually be extremely synergistic. So since you asked, that was a thought.
And I'd like to just add on to Dr. Bell. I completely agree with you. I would add IHS, so the Indian Health Service as part of that, as well as Veterans Administration. I know that there's some conversations that have been on emails trying to connect Veterans Administrations to the sepsis work that's being done. The other thing I think that I concur completely with what Dr. Klein said in terms of our ability to partner, but also leveraging those partners. Each of us have a unique set of partnerships, So CMS has its QIOs. CDC, I'm not sure what you call your partners, but we call them state partners here at ARC for you all. And then we have our own state partners, and thinking about how we can leverage across those partnerships and bring you all to the table to help inform our partners in terms of what's going on and what can be done. But it's interesting. Each of our operating divisions has a group of people that we work with to implement that which we see in terms of the evidence. And I think it's important that we connect on that front and also bring you all to the table.
Wonderful.
That's very helpful. I mean, thank you for those responses. Those are great ideas. I mean, I guess I'm also thinking, having looked at, I think it was 9 years of SEP1 and basically kind of a plateau. And I'm thinking, Dr. Owens, of your data about sepsis going up, and I'm thinking about where we are with vaccination and immunization to prevent infections and sepsis. It feels to me like there needs to be a process in a room where people stare at those numbers and say, not good enough. What are we going to do? We're doing all this, we being our collective we, including in sepsis. But here's where we are. We're stuck, and the rates are going up, and we're still challenged getting people to get flu vaccines. So how do we do what we do? Not, again, using general principles about quality improvement. How do we not just do the same thing that we're doing, just harder and faster, but how do we think about how we do something new and novel? Because I would submit that to really break the patterns of where we are and the trends of where we are is going to take some real novel and different kinds of activities. And part of it, in my mind, at least historically, has been collaboration. Some of it's creativity, some of it's breaking eggs. But those numbers to me are challenging. They should challenge all of us. Because to me, while there's been progress, including the New York numbers, by the way, which, have also sort of, flattened, how do we actually continue to make improvements? I think should be a challenge to us all. And I just wondering about time and place and facilitators where all of us are able to look at those numbers and talk about what we're going to do next that's going to make a difference. But your suggestions and comments, I think, were really great. Thank you for that.
So I'd like to thank the panel for all the participation you've done here today, as well as all of the work that you and your teams have done in the past year, and advance thanks for what I know is going to be continued work as we move forward, certainly on the things that we're hearing